So next is diagnostic hysteroscopy. Has it been, did you all get a chance to do? All of you did? Not yet. How many of you have done? Once you have done with hand holding?
Yes, I'm only like maybe
Okay. So history about hysteroscope is almost dealt. Okay. So whatever we use today are modifications of Nitze's cystoscopes. So Nitze's cystoscopes are the ones which were modified and using it. Okay. This is how big the size of the sheath it was earlier, and there was a light candle and then an eyepiece through which light would get reflected in and you would be able to see. So today Hamo's microhysteroscopes are the ones which are regularly being used. So any hysteroscope which is less than 5 millimeter, telescope less than 5 millimeter is microhysteroscope, or present days third generation hysteroscopes, where which was actually made by Hamo, and then only it became popular. So even though people have done visualization of the uterine cavity way long back, the field was not much developed. It became very popular and the field of hysteroscopy developed only after 1980 and 90, when Hamo developed instruments which are 4 mm or finer diameter ones. I don't need to go into these small details. So contraindication, PID, infection, pregnancy, recent perforations, and if the patient is having bleeding. Suppose patient is having a bleeding and scan is showing a endometrial polyp. What do you do then? Because she is bleeding, you will say hysteroscopy is contraindicated. Mm-hmm. Yeah, for a diagnostic purpose. Suppose patient is bleeding, already once DNC is done, you don't know what is the problem exactly that is happening inside. So you will not post again for her for the same procedure like DNC if your medicines don't stop the bleeding. So in that case, you have to use a diagnostic sheath which has an inner sheath, and a diagnostic scope which has an inner sheath and an outer sheath. So the outflow sheath of the diagnostic hysteroscope will help in clearing the blood clots and the blood, and then you will get a better vision so that you will be able to identify the pathology. Then only you can do a definitive procedure. So all these are same. So types of hysteroscopes, when it comes, rigid hysteroscope, contact based hysteroscopes. Contact based hysteroscope is easy to perform but difficult to interpret. Generally contact based hysteroscopes are done as salpingoscopes, where through the uterus you enter into the tubal lumen, and then actually you would have stained the tubal lining with a dye, vital staining, and then when you go in and see, you can count the number of nuclei that you can count. Based on the number of nuclei, there are some calculations like 100 nuclei per field, all those, they tell the quality of the tubal mucosa. Okay. Then flexible hysteroscopes are not that famous because, as I have told you, they don't give a better quality vision as compared to a rigid hysteroscopes, and they are expensive and durability is less. So microhysteroscopes are the ones which we use today.
so this flexible ones I use this office hysteroscopy.
Office hysteroscope, but to off late even office hysteroscope is being done through a rigid hysteroscope itself. You cannot buy two equipments for each procedure. If you are doing in the OT a different one, if you are doing it in the office, you cannot. You can just buy one instrument that is a rigid one, which you can use it for a office based also. So this is the conventional one, where you have a 4.9 mm sheath to a 3.9 mm scope. So scope is 4 millimeter and this is 5 millimeter. There is only one sheath. So this is for the inflow basically. there is no outflow sheath in the diagnostic hysteroscope. But newer hysteroscopes are coming with, newer sheaths are coming where you have an outflow track also for a diagnostic purpose. Again the same rod length system, there is no change in the principles of all these things. There is something called a 1.2 mm. So the telescope is just 1.2 millimeter thick. What is the name of that telescope? You will read and tell me. Four mm scope gives very good sharp and clear vision, and the image on the monitor is extremely good. So we generally use a 4 mm, but of late we all have shifted to a 2.9 mm. Okay, so this is how a 0 degree would work, and this is how a 30 degree would work. So ideally 12 degree and 15 degree gives very good vision, but for each one procedure you cannot buy a telescope. So you buy a 30 degree scope, which will be helpful for both diagnostic and operative purpose. So this is a flexible hysteroscope where you have a knob here, rotating knob, which flexes the tip of the hysteroscope. Okay, so it's a 4.8 mm soft flexible front, which can range from 120 to 160 degrees, and rigid rotating middle portion. So this is a rigid portion, this is the flexible one. Only problem is it gives a ground glass quality of vision and durability is less. Hammos microscope, the finer diameters less than 5 millimeter, magnification can go as high as 150 times. Generally our regular magnification is 1 in 20. Okay, when it comes to contact where vital staining of structures is done, I told you, no, that one is 150 times magnification, but this is a contact based hysteroscope. So the uterine cavity is a collapsed structure. To distend the uterine cavity, to visualize what is exactly happening in the uterine cavity, a intrauterine pressure of 40 millimeters of mercury is sufficient. So how do you achieve 40 millimeters of mercury pressure? Yeah, the distension media you have to achieve 40 millimeters. So how do you know what do you do to get a pressure of 40? Okay. TURP set is nothing but it's just the cable. You hang a 1 liter saline bottle 1.5 meters above the patient's waist, level of the waist, that will produce a pressure of around 40. Okay, so if the pressure reaches 70, then oviduct would open and fluid would go through that. So what will happen if it opens up? Okay, then if you are doing a office based hysteroscope, patient will have pain. So if you are doing a office based hysteroscope, you should make sure that the pressure is less than 70. Okay, or else she will not allow you to do hysteroscopy. Lindman was the one who used carbon dioxide for hysteroscopy, especially diagnostic hysteroscopy. Even today in few centers in US and all, they use carbon dioxide itself, but generally we don't use it. The advantage with carbon dioxide is there is no fluid spillage, it is less messy. Okay, but the drawback with that is you should have a hysteroflator. So like how you have a insufflator for laparoscopy, you should have a hysteroflator which helps in creating a pressure of 80 to 100 mmHg with a flow rate of 62 ml of carbon dioxide per minute. When you set this flow rate and this pressure, then you can see. Okay. The thing is, clarity is good and maximum angle of vision, and it doesn't interfere when there is bleeding. Whereas normal saline interferes with bleeding. So normal saline, distilled water, all those, what happens is when there is bleeding, the field of vision gets compromised. Now, when it comes to distension media, there are three types of distension media apart from gas. So, one is normal saline. So, basically it is low viscosity fluid and high viscosity fluid. We have isotonic fluids also, but this is based on viscosity we are talking about. So, low viscosity fluids are the ones which we regularly use. So, of them we have the normal saline, which is the most commonly used. Then we have 1.5% glycine and 3% sorbitol, which are actually hypoosmolar. Hypoosmolar and hyponatremia can happen. Okay, when the glycine is at 2%, that is the isoosmolar solution. So basically glycine 2.2% is isoosmolar, whereas glycine 1.5% is hypoosmolar. For diagnostic purpose, we don't use any of these. All we use is the saline. Okay, but if at all you are using operative and you are using glycine, what is the glycine that we use regularly? What is the percentage of glycine? Is it 1.5 or 2.2? 1.5% glycine. Why do you want to use a 1.5% glycine when you have a isoosmolar fluid? Because glycine concentration causing causing complications to the patient due to glycine content itself will be very high. So, to reduce the incidence of glycine related toxicity, you don't use a 2.2%, you use a 1.5%. See, this is a bag where pressure can be created because there is a bulb here through which you can create a pressure. But here there is a measuring sphygmomanometer kind. So it tells how much is the pressure. Okay. So if you just place the bag 1.5 meters above the patient or 4 feet above the patient, itself is sufficient enough to get good distension of the uterine cavity. Then this is the Karl Storz hysteromat. So what are the components of a hysteromat? So saline bottle which is there is connected here. There is an arrow mark here, see, and then there is one more opening here. So the tubing which is connected to the hysteroscope will get connected to this. So fluid will come in, a set pressure will be achieved, and whatever flow rate we have set, at that flow rate and that pressure the fluid comes out from here. Okay, so this is for the pressure, this is for the flow rate. Okay. So when it comes to low viscosity fluids, they are readily absorbed into the peritoneal cavity and the cost is less. And it is easily available in the OT. All the OTs it is available. It's not like it's a special equipment or a special media or something. Normal saline is available everywhere. Next, the drawback is, as I said, it easily mixes with blood. Hence, visibility is compromised. Hence, a continuous lavage system is required. So, for continuous lavage, you will have to have a outflow sheath also. Not just an inflow, but an outflow sheath. Yeah, you get 2.9 mm telescope, which has both inner and outer sheath. For a 4 also you have, but the problem is 4 the inner sheath is 5 through which the fluid goes. So the dirty fluid will come out through the channel between the inner sheath and the outer sheath. So that will make it 6 So without dilating the cervix, negotiating the hysteroscope will be challenge. Whereas if you have a 2.9 so 3.5 or 4 will be the inner sheath, 1 more millimeter will be the outer sheath. Relatively easier. Next we have the high viscosity solution, that is dextran 70 or Hiscon. This is not very regularly used, but in some centers for diagnostic purpose they use it. Here you have a connecting tube and then you have a 50 cc syringe in which Hiscon is taken and then it is pushed in. So the Hiscon will come through this and it's like a very viscous solution. So what happens is it will not go into the tube and then it will not spill generally, because you cannot push so much. Second thing is, because it is highly viscous, a small amount of solution itself will be sufficient to distend the uterine cavity. Vision is not compromised with bleeding. Very good vision is obtained. Okay. Peritoneum is not harmed by spillage into it. Simplicity of use and excellent light transmission. Does not escape through the fallopian tubes, so distension is maintained. It does not mix with blood, so vision is always good with this. But what are the problems with this? It is difficult to infuse through the hysteroscope. Instruments must be washed immediately in warm water to prevent crystallization of that fluid, and it may cause blockage of the stopcocks. So as soon as you do the case, you have to wash it, or else it will undergo crystallization. Then there is a 0.05% chance of anaphylactic reactions. Pulmonary edema is around 0.1%. See, basically what happens here is, suppose this gets intravesicated into the vascular channel, because it's a hyper viscous fluid, it will draw fluid more and more body water into the vascular channel. So even a little amount of intravasation will draw a lot of water. So vascular overload can happen very fast. That may lead to pulmonary edema. Okay. So what are the things that you will arrange in your diagnostic hysteroscope trolley? One is the diagnostic sheath and the telescope. Then we have the sponge holders, 2 sponge holders. Then we have dilator sets, sound, valsalum, 2 Alices are there. Generally we keep 2 Alices. I don't like to use valsalum, I use 2 Alices. I put 2 Alices, one at 2 o'clock position, one at 11 o'clock position. So the tearing or the cervical trauma is less and the pressure is much better. See, basically what we want is the monitor to be actually just above the level of the patient, in front of you, right in front of you. So if you have a wall mounted monitor, you can just drag the monitor and keep it right in front of you. You can see. If it is in the side, then ergonomically it is not the ideal one, because you have to turn your head to one side. Okay. So generally for diagnostic hysteroscope, early proliferative phase is what we prefer to do. Then dorsal lithotomy, everything is the same. Okay, we don't catheterize the bladder at all. We make the patient pass urine just before taking into the OT, do the hysteroscope, and then she can go back to the recovery room and then to her room. Conventional hysteroscope, a speculum is introduced, either a tenaculum or a valsalum or an Alice is used to catch hold of the anterior lip of the cervix. We don't give local anesthesia because patient is already under general anesthesia, and then routine dilatation of the cervix is not done. All of you have now understood by now how it functions. So when you want to see the posterior wall, keep the cable at anterior position or 12 o'clock. When you want to see the roof, then you keep the cable at floor. Left, keep the light cable at right. If you want to see the right ostia, keep the light cable at left ostial level. See, basically in what direction you should enter. Okay, so the direction, if you keep the telescope in such a way that you go like this, then you will actually perforate the posterior wall. Suppose, no, I will go straight because the cervical canal is straight. No, if you go straight, to not touch the cervical mucosa, your canal, that is the black hole that you are seeing, that is the canal, cervical canal, should be placed at 6 o'clock position. When the cervical canal is seen at 6 o'clock position, that means you are going in the right direction. Here the cervical canal is in the middle. So if you see, basically what you are doing, you are seeing the monitor. You are seeing the monitor and going straight, thinking that if I get the cervical canal in the center of the monitor, then my telescope is going correctly and I will not either injure the anterior or the posterior. But when you actually do this, the hysteroscope will be in a downward direction. You will go and perforate the posterior wall of the cervix. So always keep the opening of the cervical canal at 6 o'clock position. So light cable at 6 o'clock position and the cervical canal at 6 o'clock position, the chances of you perforating the uterus is very unlikely, or the cervix, very, very unlikely. When it is a anteverted uterus, suppose the same patient has a retroverted uterus, then probably you may have to change the light cable position to 12 o'clock to bring the cervical canal at 6 o'clock position. Okay, so basically this is the cervical canal. This is the cervical canal. In an anteverted uterus, it is like this, the cervical canal. Whereas if it's a retroverted, it is like this. So you have to go like this and then fall back. Whereas for an anteverted uterus, you go like this and you are already there in the canal. So the direction in which your hysteroscope you are doing is like reverse of a outlet forceps. Forceps, what do you do? Sacral hollow is like this. So first is downward, forward, and then upward. Do the same reverse. So upward, forward, and then downwards. You are in the uterine cavity. Okay. So that is what you should do.
So the light cable has to be at the 6 o'clock.
6 o'clock position, so that the cervical canal, that is the black hole, is seen at 6 o'clock position.
Sir, why light cable? When light cable is at 6, how does canal?
You have to move your telescope also up and down. Say you have put the light cable at 6 o'clock. The black hole is at 12 o'clock position. That means you have to antivert your hand much more. When you antivert your hand, that is when you go down, then the black hole will start to come down. That is the right direction. This generally theory won't help. When I operate and if I show you, then only you will understand.
Some people use mesoprost as priming.
In the modern hysteroscopic era, we don't prime the cervix because we use a 2.9 mm hysteroscope. Suppose patient has had history of cervical stenosis, prior surgeries on the cervix, unable to do an IUI also, or an embryo transfer is not possible. In those situations, yeah, you keep a cytolog so that when you are doing the hysteroscope, it may help you because it would have softened. But when do you keep, how much to keep and all, again is a dilemma. Generally what we do is 200 to 400 microgram 2 to 4 hours prior to surgery. That is more than enough. If you keep it too early, cervix will become so soft, some people may start bleeding, it may tear. Okay, cervix may tear, and then sometimes even if you haven't dilated, the os becomes so patulous, it will start to leak. The fluid starts to leak. So those things should not be done.
So like even with pinpoint loss also we'll be able to negotiate, sir. If two previous LSS or three years.
Comfortably.
Sometimes it will be difficult to pass the sound or
Sometimes, so many times it will be difficult, but you should know how to enter.
sir, the service if it is deviated or
So you done a PV, there is an adnexal mass in the left adnexa. So you know the uterus is being pushed to the right, and then when you put in a speculum, you see the cervix pointing the opposite direction. So you should know how to go there also. So most important thing is, till you master the art of hysteroscopy, don't miss each and any step. Like EUA is very important. See, when I go to IVF centers where they are doing hysteroscopy, if you see IVF specialists who do a hysteroscopy, they will always catch hold of the cervix, they will always dilate the cervix, they will always pass the sound before they do a diagnostic also. Forget about operative, for everything they do. We don't touch the cervix at all, we don't even touch the cervix.
then when you do vaginoscopy,
Everything by vaginoscopy. Even if you are doing a conventional hysteroscopy, you never pass sound, you never dilate the cervix, because this is a procedure with vision, under vision. There is a meaning for it. If you put a dilator, if you put a sound, endometrium gets scraped or false passage created, she starts to bleed, your vision is compromised. Once your vision is compromised, you tend to make mistakes because anatomy is not clear at all. That is very, very important. Generally, I tell all my students not to dilate, I tell them not to even sound. If you are a person doing scan for your own patients, do the scan and find out whether it is antiverted, whether it's retroverted. Everything on scan you get to know. To know whether the uterus is antiverted, retroverted, you need not sound the uterus prior to hysteroscopy. You got it? Do a bimanual examination. Majority of the times you will be correct. 95% of the times you will be correct. 5% of the times it may not correlate. It's still okay. But at least you have a fair amount of knowledge when you're doing a hysteroscope. Okay. Second thing is, the advantage of the cervical rugosities is what you should look for. So that will guide you. So this is how it looks on inside. So this I am not going to tell again because it's already been dealt. So antibiotics generally we don't give, but at the max what we follow is 1 dose of third generation cephalosporins, 1.5 gram IV, half an hour prior to induction. Only if patient has, suppose you are planned for a hysteroscopy, patient has severe vulvovaginal candidiasis, what do you do then? You abandon it? What do you do? Nicely toilet the vagina with saline and then with betadine. Make sure that the whole mucous secretions that are there, everything is cleared off, and then go ahead with a hysteroscope. And then immediately following hysteroscope, you start with, you put one capsule of cans of clotrimazole with clindamycin. You start off right away. You don't need to wait like patient let her get discharged and then let her. You put it in the OT itself. So because you have already intervened there, it is important. So what are the hysteroscopic findings in the reproductive age group? It can be a proliferative endometrium, it can be a secretory endometrium, it can be a atrophic endometrium. Okay, and then benign conditions you all know: polyps, myomas, endometritis, synechiae, placental remnants can be seen, uterine malformation, foreign bodies like copper T. So when it comes to proliferative endometrium, see a proliferative endometrium, you will see small holes, that is the opening of the glands. Small white dots are there throughout and it is pinkish in color. Okay, pinkish in color, small dots are there throughout the cavity, that is the opening of the glands. That is in proliferative. Whereas in the secretory phase, it is magenta red or velvety and lushy. So even a little you move the hysteroscope, the endometrium scrapes off. So that is in the secretory phase, and then they will start to bleed. Then the other thing is, in the secretory phase, generally the fluid, when you distend the cavity, there is a hazy or some particles are there inside the cavity, whereas in proliferative phase those things are not seen. Atrophic endometrium, it's a bald endometrium which is whitish. Occasionally some areas of punctate red lesions, that is end arterioles are seen. Abrupt ending of the arterioles will be seen in the form of punctate lesions. Okay, so atrophic endometritis. So when it comes to myomas, type 0, type 1 and type 2 myomas are there. When we are doing operative hysteroscopy, we will tell in detail how to classify whether it's a type 1, type 0 or a type 2 submucous myoma. So how do you differentiate between a myoma and a polyp? Purnima, hello.
Polyp will be tongue-like shape.
Huh?
Tongue shape polyp.
Always it should be a tongue shape. Mm.
Fleshy.
How do you know? You don't feel it, isn't it? Myoma also will have a pedicle. Okay, one. Then
Myoma will be very.
see, what are you seeing? So appearance is what you should talk about. Appearance gives a lot of information, because based on appearance only you are identifying the structures. Feel, touch, nothing is there. So how does it appear?
Vascular.
Fibroid polyp will look more whitish, whereas a endometrial polyp will look pinkish. It's of the same color as that of the endometrium. Okay, whereas the polyp is having the same color of endometrium, whereas submucous fibroid will be more whitish. Then in a submucous myoma, there is peripheral vessels that you can see, peripheral vasculature, whereas in an endometrial polyp there is a single feeding vessel through the stalk of the polyp. Then polyps are the ones which flap. Endometrial polyps tend to flap because they don't have any substance in it, whereas submucous myomas, they do not flap. Okay, so these are the common differences between an endometrial polyp and a fibroid polyp. See the appearance, how it is. It's same as that of the normal endometrium. So this is a cystic polyp, that is cystic degeneration or changes that are happening. So it's become like a cystic lesion. 1, 2, 3, 4, 5, so many are there. Okay. So these are intrauterine adhesions, that also we will deal with when we are doing a operative hysteroscopy session. Flimsy adhesions are mild adhesions, basal endometrial tissue is still intact. So that kind of case, the results are very good. They are fragile, soft and whitish in appearance. They may be partially or completely occluding the cavity. When it comes to moderate type of adhesion, it's a fibromuscular thick band covered with endometrium which may bleed on division. Okay, and it can be partial or complete. What are the severe types of intrauterine adhesions or synechiae? Only connective tissue or fibrous tissue is there. When you cut, it does not bleed. There is no endometrial lining over that adhesion band. Those are the ones which are very bad, because the basal endometrium has been gone or damaged off. So there is no basal endometrium. So you may do the surgery very well, but what is the outcome? Basal endometrium as such is less. So for endometrium to regenerate, we will have to help separately. Okay, hormone replacement therapy has to be given. And patients who have oligomenorrhea or amenorrhea are more likely to have loss of basal endometrium. Okay, that is very important. Next, foreign bodies, then endometritis. I will show you one more case of endometritis. Then this adenomyosis. What are the features of adenomyosis that you can see on hysteroscope?
Adenomyotic spots are seen.
Okay, what do you call those adenomyotic spots? Deer spotted appearance. Like how a deer has multiple spots, in the same way brownish spots are there.
Sir, how would you differentiate this and endometritis?
Endometritis is different. Endometritis, the vascularity is high, and then the thing is micropolyps are seen in endometritis. Whereas in this, micropolyps are not seen. You will have craters or clefts within the endometrial cavity. So subendometrial blood clots are seen, and then these spots are seen. Crevices. So adenomyotic crevices are seen, fibrous adhesion bands are seen in the fundus. You can see deer spotted appearance. So all, and you can see actually brownish fluid coming out of the crevices or the glands in adenomyosis actually. So malformations like septum. So in septum, again, when we do operative hysteroscopy, we will deal with septum part.
How will you be able to see adenomyosis in hysteroscopy? Layer of endometrium.
So where will that endometrium adenomyosis, where will it actually start from? Does it start in the myometrium per se? There should be the endometrium that goes from the endometrial side towards the uterine side, isn't it? That is what is happening.
That is what we visualize from.
So early adenomyosis can be seen on hysteroscope, not even on scan. So in a hysteroscope, when you see that, when you do a hysterolab, when you see the external indentation to be very minimal and the internal indentation to be more, that is a septum. So when it is an external indentation less than 1 centimeter, less than 5 millimeter, and an internal indentation more than 1.5 centimeter, that is called a septum. Up to 1 centimeter, it is still considered to be normal, like an arcuate uterus. Okay. What is this? Placental bits. So patients with incomplete abortions, failed MTPs, you can do a hysteroscopy, get a image. So what is this? Bony fragments here, here. So it can be de novo metaplasia of the endometrium into calcific metaplasia or a bony metaplasia, or the second one can be your second trimester miscarriages, you are left behind the fetal bones. Okay. Then when you see endometrium, which in patients with AUB, like there is increased thickness of the endometrium, dishomogeneous regeneration is there, increased vascularity, presence of ciliated images or cystic dilatation is there. So some area excess growth is happening, some areas less growth is happening, some areas it is highly vascular, some areas it is normal, the vascularity as such. So that is suggestive of a probable endometrial hyperplasia which has low risk for malignancy. Okay. So when you do a hysteroscopy, you have to tell your patient, isn't it? okay, this is looks like hyperplasia but doesn't look like malignancy. So that is what you should tell. Whereas high risk for endometrial hyperplasia is polyps are often present, abnormal vascularization which produces an arborescent appearance. Here arborization, irregular branching of the blood vessels are seen. Okay, and the architecture and organization of the uterine cavity is altered. So this is a high risk for endometrial hyperplasia. Then how does a malignancy look like? You will have papillary lesions which is friable, which bleeds on touch, vascularization is extremely irregular and anarchic. So papillary appearance, fragile necrotic tissues also can be seen. Because of the rapidity with which the cells are multiplying, the blood supply is not sufficient. The superficial layers are already undergoing necrosis. So generally, if you don't know the diagnosis that it's an endometrial malignancy, you can still do a diagnostic hysteroscopy to confirm whether it is malignancy. You need not say, okay, I am suspecting, I will not do hysteroscopy. Agala. Whatever spill happens will not upstage the disease. That is the thing. So your malignancy will not be upstaged to third grade or anything, stage 3 or anything. So it has been proven. Only thing is, when you have a higher suspicion, what you should do? Experienced person who knows to do hysteroscopy in a fast manner, like just go in, see where exactly is it a focal lesion or is it a pan. If it's a focal lesion, go take a grasper or scissor, cut it, take a biopsy and come under vision. That is hysteroscopic guided biopsy. That is where the advantage is. If it's a pan, then you can take a curate and then take samples from any part of the endometrial cavity. But if it is a localized pathology, you have to take a directed biopsy. Again, in infertility, it's very helpful, and lot of women undergo hysteroscopy prior to IVF embryo transfer. It's better to do it than like, okay, I have missed a polyp or something which some other doctor finds out. Rather you do a hysteroscopy for all of them, but routine hysteroscopy prior to IVF is not recommended. By guidelines it is not. A lot of people do it, but it's not mandatory. So next is the ostium. This when it comes to tubal block, cornual blocks, I'll deal in detail when we are doing the office hysteroscopy. Okay, submucous myomacy, the vascular, peripheral vascularity, and then you have the septum. So when it comes to AUB, you should never tell them I will do a diagnostic diagnostic cum therapeutic fractional curettage. Earlier fractional curettage was the modality of investigation. What is fractional curettage? So you should not tell them. Today in the modern gynec practice, you should always offer them hysteroscopy. Hysteroscopy plus guided biopsy. That is what you should suggest for any woman who is coming with abnormal menstrual bleeding, even for women with postmenopausal bleeding. Postmenopausal bleeding is another type of abnormal uterine bleeding based on age. Okay, so basically the ability to detect endometrial malignancy is 100% by hysteroscope, and ability to detect high risk hyperplasia and low risk hyperplasia is also very high when it compared with either a blind DNC or a people endometrial biopsy. So one of my first cases when I was doing my fellowship itself, when I was having few patients of my own, The first patient whom I did a hysteroscope was a lady who was referred to me for hysterectomy. She was a 35-year or 37-year-old lady who had menorrhagia. She had already undergone a hysteroscope, D&C, and that didn't solve her problem. Then I did a scan, I felt there is a polyp. So I told her, treatment or two. If you don't want any kid, she already had one kid. So she actually wanted one more kid. She wanted a girl child. So she said, actually, I want one more child, but I have been referred to you for hysterectomy. Then I said, nothing like that. If we do a hysteroscopy and solve the problem, your bleeding problem will solve, and then you can conceive. When I put in a hysteroscope, there was a polyp of around 2 centimeters, which was actually missed by blind DNC. And that blind DNC was done by a very senior doctor. Okay, so such small things will make a lot of difference. Actually, 8 months following hysteroscopic polypectomy, she conceived spontaneously. So we should not dictate what is going to. You should do what is needed for that patient. Let it take its course. But you should always tell, see, I will do a hysteroscope, take out the polyp. Conception, either you will have to get treated. Second thing is, even after doing that, if your bleeding doesn't stop, then we may give a try of Mirena, and then even if Mirena doesn't work, then we can go for hysterectomy. Right away, directly, if you go for hysterectomy, I don't think it's justice done to the patient in the present day. You should try the medical management so that you can avoid a hysterectomy. In the same way, you can even avoid complications during that surgery. If you had not done the surgery, unnecessary complication that complication wouldn't happen. So when there is a complication and when they scrutinize your file and they tell, okay, this was not a real indication at all, you could have given the medical line of treatment, or you could have used the alternative modalities of treatment to solve the patient's problem, then it is almost pointing towards the doctor that it was a wrong decision. Advantages, all of you know: short hospital stay, easy learning curve, faster recovery, pain is absolutely very minimal, you can avoid a hysterectomy, but the exact pathology can be found out, early stage malignancy can be picked up, or pre-malignant lesions. So now when it comes to complications, so procedure related problems, vasovagal reaction if you don't give, if the patient is not under anesthesia, and then cervical lacerations during tenaculum usage or valsalum, uterine perforation because you are trying to sound the uterus or dilate the cervix. If it perforates at that stage itself, then you cannot do hysteroscopy. Okay, then if the patient is bleeding or poor visibility is noted, then media related complications we will deal with you when we are dealing with operative hysteroscopy and its media related issues. When it comes to post-op, infection can happen if you don't maintain proper asepsis. Your inadvertent use of the hysteroscope and curette and other things can cause synechia, and failure to treat when you have perforated the uterus or the cervix right before itself before you complete the procedure. So when you are doing a hysteroscopy, if you find bleeding through the cervical canal, so probably it can be a partial perforation or a complete perforation. What do is immediately abandon the procedure. Monitor the patient's vitals. If the patient is stable, no need to do anything. No need to. Laparoscopy should be done only when the patient is unstable. Second, you have done a hysteroscopy, diagnostic hysteroscopy. Vaginal bleeding is not there much, but patient is desaturating or patient is developing tachycardia, going in for hypotension, abdominal distension. That means intraperitoneally she is bleeding somewhere. So that is an indication. If you are using a energy source based resectoscope kind of a thing, and when you are resecting something, that time perforation of the uterus happens, then you should do a diagnostic, not for all cases. See, there is a perforation here. again here also. So you have to be extremely cautious. So this is a Collins knife. So what are the factors which predispose for perforation of the uterus, cervical lacerations? When there is cervical stenosis, when there is acutely anteverted and acutely retroverted uterus also, it may cause. Postmenopausal women, the cervix is soft and it is taken up, the cervix is flush to the vault, and then when there is pyometra, hematometra, and then there is malignancy, the uterus is very soft, so chance of perforations are very high. Pathologically, like distorted cavity, intrauterine adhesions, anomalies, hyperplastic uterus, all these. So when it comes to anatomy of the uterus and cervix, when the uterus is under distension, the wall thickness is around 2 centimeter and at the cornu it is around half centimeter. So even one small wrong move can open up the cornua fully. So at that stage, stop the procedure, assess the patient's vital status, look for pain and bleeding. You can repeat a HSG after 3 months. So intravasation, by chance air enters through the histomat or anything, it can cause air embolism. Okay, second thing is it can cause fluid overload causing pulmonary edema, it can cause cerebral edema. Okay, so pulmonary edema, anaphylactic reactions and coagulopathy can happen with Hiscon. With intravasation of liquid, pulmonary edema can happen. So you should be extremely cautious when you are doing a hysteroscopy. So this TURP syndrome or TCRE syndrome we will deal once we are dealing the operative hysteroscopy and complications per se. But as such, for almost all cases of operative hysteroscopy, before you post the patient for surgery, do a baseline serum electrolyte levels. Always. Baseline serum electrolyte levels you have to do. So baseline evaluation of the serum electrolytes is important because suppose when you are doing surgery, patient has some symptoms and you want to find out whether there is hyponatremia set in following surgery, you will get to know. So always have a baseline. So when the sodium levels is between 135 to 145, that means the status is normal, no need to do any treatment. When the level is between 120 to 135, patient starts developing restlessness. Okay, that is the time when the patient tells I am restless, I am not able to tolerate, I am feeling uncomfortable. So that is the time when you should see whether the intravasation of fluid is happening too much, whether the intrauterine pressure is very high, whether procedure is completed or not, what is happening exactly, you should have a status so that you stop the procedure as soon as possible. Try to complete if minimal procedure is left behind. When the levels is between 115 to 120, confusion and restlessness sets in, and then at that stage you have to give oxygen, 0.9% saline, give Lasix or furosemide, 40 to 60 mg per kg, 40 to 60 mg bolus. Then you may have to ventilate the patient. That means till now patient was under spinal anesthesia, so patient is able to talk. So operative hysteroscopy, regional anesthesia is preferred over general anesthesia. Next, when the electrolyte sodium levels are between 110 to 115, nausea, headache, sleepiness, arrhythmias, hypotension sets in. So you have to pick up the problems at this stage, not just at this stage. Okay, at that stage when you pick up, there is already hypotension, sleepiness and headache and nausea. So in that situation you give a hypertonic saline, 3% saline you give so that when you give hypertonic saline, the fluid will get away from that area. Furosemide Lasix, that is 1 mg per kg body weight every 4 to 6 hours. You can even sedate the patient for prevention of seizures. Okay, when it is less than 110, arrhythmias, fibrillation, seizure, hypotension, coma, death are possible. When it comes to glycine toxicity, there can be transient blindness which can persist for 24 hours due to the inhibitory effects of glycine on neurotransmission. There can be convulsions which can occur because increased effect on NMDA receptors and dilutional hypomagnesemia. So toxicity by byproducts, it is glycolic acid which gets converted to oxalate and causing hyperoxaluria. Hyperoxaluria is a nephrotoxic agent. Next one is it gets converted to oxalates, and the other one is the release of ammonia. Ammonia can cause encephalopathy, cortical edema, nausea and vomiting. So preferably when you are using normal saline, so these are the old guidelines, just listen to me. When you are doing a operative hysteroscopy, when you are using glycine, okay, when you are using glycine, 500 to 750 ml is the cutoff for low risk patients, for high risk patients. When it is low risk patient, you can go almost up to 750, okay, or almost up to 1 liter. 500 is the cutoff for high risk patients, 750 ml is the cutoff. Maximum 1 hour you can operate. 9 liters of glycine you can use, that is 3 liter bottle, 3 you can use, okay, and then not more than 1 hour. Whenever you have any changes in the patient's vitals or anything, you stop the procedure for a while and try to keep the intrauterine pressure less than the mean arterial pressure, that is less than around 150. Don't keep too higher intrauterine pressure. When it comes to normal saline, the thing is it is 2500 ml is the cutoff. But 1 hour procedure, all those things are the same. So it's a time dependent. What you should understand here is in when it comes to hysteroscopy, lot of us take it very lightly. Oh, it's just a hysteroscopic procedure. But the problem with hysteroscopy is the threshold between morbidity and mortality is very narrow. So patients who develop a morbidity, the chance of them having a mortality is very high in hysteroscopic procedures as compared to laparoscopic procedures. Laparoscopic procedure at the max, what happens? One vessel injury, bleeding will happen, you give blood transfusion. Bowel injury happens, you suture the bowel. Bladder injury happens, all those things. Whereas with hysteroscope, when the system is affected, cardiovascular system is affected, normal physiological electrolyte imbalance is affected, the morbidity to mortality percentage or chances is very high. So never take hysteroscopy lightly, never ever, because you will end up in problems. You may think, oh, you would have even told the patient, hey, hysteroscopy is a very simple procedure, don't worry. So patient will come in bike with husband. Luckily, if she comes with someone, if she comes alone, so you cannot take any procedure lightly for that matter. So this I have already dealt. 400 microgram or 200 microgram prior to surgery, 2 to 4 hours. Not everyone we use. Again, these are not important. What is this? Submucous myoma. What type? Any differential diagnosis? ಹಿಂಗೆ ಊದ್ಕೊಡಂತ. ಮುಬೇಕಾ endometrial polyp. Pregnancy, it's a pregnancy at 5 weeks. It's a sessile. See this, it's a sessile thing, it's not a pedunculated.